friends, today I am going to introduce all you about the topic that is mitral regurgitation. Now, as you have known all that it is a cardiovascular topic, that is cardiovascular system related topic. So I made this video separately because I have discussed about mitral stenosis and whatever the left part in previous videos. So I'm making a video separately on this topic. It is not that much important, but yeah, you should know about this, that what it actually happens. Sometimes a combined question comes in a paper in which they ask about both of the things, that the question might come in a paper about mitral wall disease. Now in that question you have to answer both the parts. First you have to write about mitral stenosis, and then you have to write about mitral regurgitation. So okay, now let's start about this. The mitral regurgitation, as you know, mitral regurgitation. Now mitral means mitral wall and regurgitation means the backflow. So in this we are talking about the backflow of the blood through the mitral wall. That is backflow of the blood through mitral wall during systole. Okay, because in the systole the blood is being passed from atrium to ventricles, and due to mitral wall problem, that is due to dilatation of mitral wall, the blood tends to go back from ventricles to atrium during systole. Now why this happens? Because due to dilatation of the mitral wall, the orifice size increases, and due to this increase in size, the flaps of the wall are not able to completely cover the orifice. That's why, and as the pressure is increased in the ventricle, so due to that increase in the pressure, the blood tends to go back from the wall to the atrium. That is mitral regurgitation. Now due to this mitral regurgitation, as the blood goes back from ventricles to atriums, so that's why volume overload, that is more volume of blood happens to come in the atrium, that is in the left atrium. So that's why volume overload of left atrium, and due to that volume overload, obviously enlargement of left atrium will occur. So along with this, left ventricle enlargement also occurs, because the volume which is being pumped from the ventricle to the atrium, so ventricle has to do more work, like to meet the cardiac output. Okay, so to meet that cardiac output of the heart, the ventricle has to pump more volume, because the normal volume which is being pumped out of the ventricle, some of the volume from that is going back to the atrium, so it has to push itself to pump more volume so that cardiac output will be maintained. That's why volume overload and enlargement of left ventricle also occurs. Now the changes that have occurred so far, that is the volume overload. Now due to these volume overload, that is the overload in the left atrium as well as volume overload in the left ventricle, initially left ventricle as well as atrium, they tackle this volume overload. They just keep on going with this and are maintaining the normal cardiac output, but with time they are not able to maintain this overload of volume, and due to that volume overload, they finally lead to left heart failure. Initially they try to cope up, but as long as the disease keeps on progressing, left heart failure will occur. Now due to this left heart failure, left ventricular pressure increases, like as we have studied in the previous videos, that we have also studied in the left heart failure topic, that when the left heart failure occurs, left ventricular pressure, that is you can say left ventricular end diastolic volume, or you can say left ventricular end diastolic pressure, they just increase, as well as left atrial pressure also increases. Now as the pressure of left atrium as well as ventricle increases, pulmonary venous pressure, which is being pumping the blood into them, they also increase. Now due to this pulmonary venous pressure increase, it will finally lead to pulmonary edema, and then congestion of lungs will occur. we have studied all this in the details about of all this we have studied in the left heart failure topic. Now, due to the congestion of lungs, some kind of permanent changes, you can say some kind of permanent changes occur in the pulmonary blood vessels. Like, some of the changes, they are permanent and they just caused due to the congestion of lungs. So there's some kind of changes that have occurred due to this. Hypoxia will occur, and due to that hypoxia, pulmonary atrial hypertension will be caused, and due to that pulmonary atrial hypertension, eventually right heart failure will also be occurred. So the main point to be noted here is that due to mitral regurgitation, volume overload will occur. Due to that volume overload in left atrium and left ventricle, left heart failure will occur, and due to that left heart failure, finally right heart failure will also occur. So this is the main thing that we need to know about mitral regurgitation. Now let's talk about the two types of mitral regurgitation. One type is acute. Now in the acute type there is rapid rise, rapid rise in the left atrial pressure, as well as rapid development of acute pulmonary edema. And this acute type of mitral regurgitation is seen in the patients having acute myocardial infarction, as well as the patients having bacterial endocarditis. Okay, now next type, that is a chronic type. Now in the chronic type there is gradual onset, or you can say slow onset of the disease, and it occur in the mitral wall prolapse. Now this topic I'm going to discuss in next video, that is an upcoming video about mitral wall prolapse. Okay, so it occurs in mitral wall prolapse, as well as it occurs in chronic rheumatic heart disease. Okay, let me write down this: chronic rheumatic heart disease. Okay, now let's talk about the causes of the chronic mitral regurgitation. Chronic mitral regurgitation occurs due to chronic rheumatic heart disease. Sometimes it also occurs due to the diseases of myocardium as well as endocardium. For example, infarction, myocarditis, endocarditis, and cardiomyopathy. So sometimes it also occurs due to diseases of myocardium or endocardium. Sometimes it occurs due to papillary muscle dysfunction and chordinae tendineae rupture. Both of the things are seen in the patients with myocardial infarction. For example, when a patient has a myocardial infarction, and in this condition, if the papillary muscle dysfunction or chordinae tendineae rupture occurs, then we can say it will lead to chronic myocardial regurgitation. Now, acute myocardial regurgitation, it occurs in chest wall traumas. Whenever there is a trauma in a chest wall, it also occurs in acute myocardial infarction, that is in papillary muscle dysfunctions and ruptures of chordinae tendineae. Acute myocardial regurgitation also occurs in endocarditis, that is the problems regarded to endocardium, that is endocarditis, that is inflammation basically. So as you can say, this topic, that is acute myocardial infarction, that is chordinae tendineae rupture, as well as papillary muscle dysfunction, as this point has come up in both in the chronic case as well as in the acute case. So you can say that proper distinction can't be made, but yeah, little bit we can say. As well as along with this, we can also say that there are many other causes also. For example, we have some of the causes which are congenital. We have congenital causes also, like cleft mitral valve or parachute mitral valve, and mitral valve prolapse, which we are talking in further videos, that is mitral valve prolapse. Next one is acute traumatic fever. Then we have myocarditis, we have endocarditis. Along with this, we have some other causes like cardiomyopathy, Morphin syndrome, we have myocardial infarction. We have told about already that myocardial infarction, this coronary annular rupture, as well as papillary muscle dysfunctions. So yes, along with this, we have another syndrome, that is Ehlers-Danlos syndrome. Okay, so all these are the causes of mitral or regurgitation. Okay, so now let's talk about some of the clinical features. Okay, so in the clinical features, we will be discussing about the two forms. That it can be for, sorry for this. Yes, so we are going to discuss about the features of acute as well as the chronic, or you can say insidious or slow form. Okay, so better than saying it acute and chronic, we are going to discuss in a rapid form or a slow form. Okay, so clinical features, that is symptoms and signs depend on the onset. Okay, all the symptoms and the clinical features, they all depend on the onset. Okay, rather it's a slow or rapid onset. Slow insidious, you can say slow or insidious mitral regurgitation produces symptoms due to volume overload. Okay, so we can say the slow form, it produces symptoms due to volume overload. And the rapid form, or you can say the acute form, it produces signs and symptoms related to left ventricular failure. Okay, that is, it produces pulmonary edema. Okay, so yes, now physical signs occur due to left ventricular dilatation. Okay, that is displacement of the apex of the heart. If we are talking about the physical signs, so there will be displacement of the apex of the heart and rapid ventricular filling. Okay, so let me summarize all this. So now let's talk about the physical signs. Now the physical signs occur due to left ventricular dilatation. Okay, there is, actually I have told you that there are the signs of acute left ventricular failure in the case of acute part. Okay, now the physical signs, if we are going to find out, and the physical signs will only be related to the left ventricular dilatation. Okay, so now due to left ventricular dilatation, there will be displacement of apex beat. Okay, second is there is rapid ventricular filling. Now due to that rapid ventricular filling, there will be a short mid diastolic murmur. We're going to find out a murmur which comes in the mid of the diastole and which is a short. Okay, it is also called as a third heart sound. So due to that rapid ventricular filling, there will be a third heart sound production which comes in the mid of a diastole. It's a short, that's why called a short mid diastolic murmur. Along with this, due to a regurgitant jet, we are going to find a apical pansystolic murmur. Sorry for this writing. It will be a apical pansystolic murmur. Okay, that pansystolic murmur will be a slightly apical if we're going to listen it through a stethoscope. Now this
apical pansystolic murmur. It can be with or without a trill, okay, and which radiates to the axilla, so it depends. Along with this, we have incompetent closure of the valves, and due to that incomplete closure, we are going to listen a muffled first heart sound. So that's the last point. So these are the physical signs. Now let's talk about the investigations.
Okay, now let's talk about the investigations. Now there are 5 investigations that we can done. First is ECG, that is electrocardiogram, and this may show left atrial and left ventricular hypertrophy and atrial fibrillations, as well as flutters or ventricular ecotrophies. Okay, so how it shows left ventricular and atrial hypertrophies? It shows a bifid P wave. It shows a bifid P wave. Okay, so this is what you need to know. It shows a bifid P wave. So by this we came to know about hypertrophies and all. Okay, second point is chest x-ray. So in the chest x-ray we can find out cardiomegaly, as well as the congestion of lungs, as well as edema, pulmonary edema. So to find out these chest x-rays done. Okay, next is echocardiography, and in this echocardiography we are going to find out what is the state of the valve, as well as we can find out about the chamber, its enlargement, as well as its function, whether properly working or not. So that's about echocardiography. Fourth is color Doppler echocardiography. In this we are going to see what is the extent of mitral regurgitation. And then the last, that is cardiac catheterization. We're going to confirm that whether it's mitral regurgitation or not. So these are the 5 investigations. Now let's talk about the management. So here's about the treatment. Now in the treatment we have 2 type of treatments. Either it's a medical treatment or it can be a surgical treatment. In a medical treatment we will be restricting salt in the diet. Secondly, we will be using some of the diuretics. We can be use some of vasodilators like captopril and enalapril. We can be using digoxins, that is a standard dose of 0.125 to 0.25 milligrams per day for 5 days a week. We can also use some of the anticoagulants, and at the last we will be using some of the prophylactic drugs. We will be using benzothine penicillin, that is 12 lakh units, for up to 3 to 4 weeks. So this is about the medical treatment. Now let's talk about surgical treatment. So let's talk about surgical treatment. Now in the surgical treatment we can do a mitral valve replacement or a repair, that is the reconstruction or valvuloplasty, when the valve disease is predominant and the severe becomes too severe and there is no evidence of bacterial endocarditis, then we are going to do this replacement or repair, that is valvuloplasty. Next is a use of prosthetic mitral valve. Now prosthetic mitral valves can be used. These are of 2 types, either mechanical or biological, and both of them are used, but difference is that mechanical are used in the young ones and biological ones are used in the old ones. Okay, so another point to be noted here, that the surgical treatment is only done when there is a worsening of symptoms and progressive cardiac dilatation and left ventricular dysfunctions. These are the things that are indicative of surgical treatment. So yes, this is how we are going to treat it surgically. So that's all for the topic, and at the last I want to say thank you for seeing this video, and if this video is a little bit helpful to you, then please do like and subscribe. Thank you.